This presentation is made available for educational purposes only to provide you general information and a general understanding of the law. It is not intended to provide, nor does it constitute legal or tax advice. The presentation should not be used as a substitute for specific legal or tax advice from a licensed professional attorney or tax consultant that you have engaged for that purpose. Further, the subject matter contained in this presentation is complex and subject to change. Any tax statements in this program are not intended to suggest the avoidance of U.S. federal, state, or local tax penalties.
Now, what we've been focusing on mostly, although we got into a little bit, is federal stuff. Now what happens is we have our state legislature coming into session here in the next couple weeks with a lot of other decisions to make that can also throw additional walnut shells into the game. What are some of those?
The biggest issues I think that hold for Florida are, of course, how we're going to handle the exchanges. I don't believe, and I will absolutely defer on this, but I don't believe there's time at this point to set up a state exchange for Florida. I don't think it's been viewed very favorably by our governor. And so that does play a part in it. So now we're going to be part of a federal exchange. And so we're waiting for the federal exchange. Whether or not the federal exchange is more beneficial than a state exchange will depend on the members, on the makeup and the demographics of the federal exchange. Certain states might have better demographics, healthier lifestyles than others. Florida, I don't think, has as healthy of a lifestyle as we'd all like sitting here right now. Neither do some of the other states like Mississippi and Alabama. And I'm not sure, and I think Mississippi and Alabama might also be on the federal exchange, but I could be wrong. So whether or not it's a benefit for us to be on a federal exchange based on the pool of employees that will be there or the individuals that will be there is still up for grabs. The second, obviously biggest concern is the Medicaid expansion. Our governor has said that they will not do the Medicaid expansion. There's a lot of controversy one way or the other on that. The issue on the Medicaid has been the cost. In many cases, it appears to have been overstated. The first, I believe, 3 years are paid at, I know the first year was paid 100% by federal funds. I think the second year, I think it's a graded schedule over like 6 years. But I don't think the state would ever pay more than, I think, 90%. So there's been some issues about what the cost of expanding Medicaid would be. The fact that we're not doing it means that we're putting more and more people onto the exchange and making more and more people potentially eligible for subsidies.
I think Mississippi, just so you know, did set up their own.
Oh, good.
Alabama did not.
Alabama's,
I think they're tied for the least healthiest states.
Yeah, I knew. I wasn't sure.
Another thing, I think one of the reasons that the state of Florida is just what you said, not doing the exchange or the expansion of Medicaid, it's that unfunded liability. They are concerned about what does that number look like, not today, but in a year, 2 or 5 or 10 years from now. So pushing into the exchange with a subsidy is the direction that I think the federal, or that the state wants to take in regards to those lower income types of individuals.
And I'm throwing this out as a question. I think I know part of the answer, but I don't want to, but there have also been some changes because of the federal legislation in the small group rules that the state insurers can do and how they can do ratings. So, it used to be that when you underwrote various small groups, you could base it on a variety of issues. Those number of issues that insurance companies, I believe, can use to rate small groups has now decreased significantly. I think there's only 5 age.
I don't know that I can name all 5 of them, but there is no gender. There is no gender.
There's no gender. There's no health.
Only up to 1.5% tobacco.
Right, and there's limits on how much you can adjust. So if you're a small group who has had a poor health history, these may benefit you. If you are a small group that has had great health history, then these might hurt you, because what they're trying to do is put small groups on more of an even playing field. So they've limited the underwriting factors that can be taken into account, and those factors are also capped on how they can address the premiums for those situations. So I think that's just another state issue that although a federal regulation might address some of the state issues as well.
And that particular issue could have a drastic effect, because for a state population to do well in an exchange, you need young and healthy folks. Well, if we know that the penalty for not taking, because you said that you offer, but some people don't.
Yeah.
Well, they didn't before. Well, now when you say, oh, and if you don't pay, let's say best case scenario, $90 a month, you're going to be subject to the penalty as an individual. Well, what's that penalty the first year? Oh, $95 annually. I mean, so you're going to have a lot of 20-something-year-olds that already thought they had the S on their chest and they weren't going to get hurt. And when they hear that they don't have to pay it, it comes out of their tax refund at the end of the year. It's $95. There's a fear that whole segment might just say, well, and they have to take me if I do get bubonic plague next year, because there's no pre-exclusions anymore. There's no, so no pre-existing. So there's that thought that the people that you have to have as part of your population in exchange to help keep rates down are going to opt out, because the penalty, as much as it was combated around as to whether or not it was constitutional, the penalty, whether you liked it or not, if you thought it was constitutional or not, doesn't matter, because it's so small, it's not going to do the job that it was intended for. You're going to have the people you want in there not going into the exchange. And that's so that point that you brought up is so huge, because the makeup of the group here in Florida, you're going to have people that, wow, now in their 50s, it's cheaper than what they could get through their employer, or maybe it's more equivalent. But for that group that we really need to have getting in there, they may miss out, and it may just have drastic effects in the
But
funnel.
just remember, if they're
Now, what
26
happens
and under,
to
they're
that
paid
guy?
on their parents.
If that guy in your example, so we offered it, he declined it. Now, does he then go to the exchange, or he's got that option too?
He
or?
only has it if your coverage is unaffordable.
Okay, so
So
we
he-
offer it, he
he
declines it,
declined-
then he's got nothing.
Yeah, the only way.
If he goes and breaks his leg, he goes to the ER and they charge him $18,000, then what happens?
And that's
He's on the hook?
And that's the loophole that part of the debate on whether or not to expand Medicaid, and whether or not this is the thought that no matter what we have set up here, you're still going to have people that say, I'm not playing until I get hurt, and then I'm playing, and you're paying for it. And because of that, some of the numbers don't add up, where you say if you expand Medicaid, you're going to have less people in the ERs, you're going to have that. But because people do still have that option to pull out, we're ultimately still going to be paying for that risk as well. So that's kind of whether or not you're
Right.
for or against it.
No,
It's that idea of, do these numbers work, because you're still going to have some of that population that's going to be
And
at
you're
risk.
always going to have some of that population. You're always going to have people who say, I'm invincible and I'm not going to do it, or I don't have kids, I don't really anything to lose. Why do this? And the concept is that the penalty, although is $95 or 1% of income, and so there is a little bit. It does go up a little bit, and the more you make, and this, that, and the other thing. But yes, there is an entire. The idea is it going to have enough of a chilling effect to say to people, well, I would have to pay the penalty anyway. I may as well just do this and move on.
And he can still go to the ER and they still can't turn him away and he'll get treated.
There are yes. I mean, he can still be treated. Yes.
And he'll run up a big bill and then.
And run up a big bill
We'll
and then
get to
try to
pay
get
for
it
it
done and
from
debate it
insurance.
and try to pay like $5,000. Although, you still have those issues too on, is it really fair to charge the guy who doesn't have insurance $18,000? But that is still their risk, and they will be hounded. And I mean, and the only way the hospital is going to write that off is if they're indigent or can't otherwise afford it. So I mean, there are limits as to how much hopefully we'll be stuck with, and hopefully it will be less. The concern and the concept is that it'll be less than what we're doing now. I mean, by having these optional alternatives available with the subsidies that, and that's the hope. And unfortunately, all we can do right now is look to Massachusetts and say, okay, and in some cases that's working well. In some cases, they still have some issues. As many of you are probably aware, the federal concept for healthcare reform was based in part on Massachusetts healthcare reform and the state arrangement and program that they put in, very similar to an exchange. They have what's called the connection. And I believe I checked the numbers, and of course, who knows which report I was looking at from whose side, so I have to apologize if these are wrong. But I believe the last thing was almost 95% of the people in Massachusetts had coverage. So I mean, they did see a distinct rise, and again, that 95% could be off a little bit. But again, they did see a significant rise in coverage, which I think at the end is really all you can hope for.
How has affordable health care impacted your thoughts on employee benefits programs?
it is always a challenge to find and keep the best people. One of the things that frustrates us a little bit is the working people. A lot of the hourly people work paycheck to paycheck, and frankly, most of them for an extra quarter of an hour would say, I don't need any health care. And you can say it's short-sighted and they shouldn't be thinking that way, but that's the way they operate.
I operated that way at 22.
And it's kind of scary. You wish you could train them and let them understand the value of this and how important it is to them. But like I said, we've got more than half of our people, but not a lot more than half, participating in the health care we offer, and we're paying a very high percentage. It's really a great deal for them. But a lot of them will just decline it, and they'll get that extra little bit each week. And what's frightening is even out of those that take it, most of them take it just for themselves. And so a lot of them are not covering their children or their spouse, and hopefully they're covered,
I was wondering if they would be covered on it.
with the other spouse or whatever. But to me, that's really the big problem. And the other thing that I always see is, one of my big hot buttons is I keep reading in the paper every year that healthcare went up 8% this year, and that's terrible. That's not true. It goes up much more than that. Our healthcare, to keep the same plan from last year to this year, was plus 20%. So what happens is every single year, to keep the increase down to 8 or 5%, which is still way more than inflation, we're dropping coverage, we're dropping the benefits. And so from 20 years ago, when we all had plans that covered all of your medical expenses, today you go to the doctor, you pay a copay, it's a little more every year. You've got a deductible for procedures and things like that, that is a little more every year. Now sometimes you got to stay in network, you can't afford to go out of network. Our new plan, you can't go out of network, you've got to stay in it. So every year it's getting harder and harder. And again, when we go to those hourly employees, a lot of them elect not to go because they say, I can't put a $30 copay in, or I don't want it. Or, yeah, I need this procedure, and that's a $200 copay or whatever, or it goes to the deductible. So,
well, I think it'll be interesting too, and you mentioned education, for employees and how things like that work. When I wear rose-colored glasses, and I'd like to think about potentially, these exchange notices possibly being used as something like that. However, I also realize that it may never be written in a manner in which half the people will understand it, or people won't read it, number one, or number two. You've got, when was the last time, and I'm an employee benefits attorney, and I sit there and say, when was the last time I read my summary plan description? It was when they turned down my pharmaceuticals, and I looked at them and went, really? Why? It's not covered, no. So there are those kinds of things where there's an inherent, failure to read and move forward and understand it. And I agree with you, there will always be the people that are going to be willing to take that risk. And when I hear you're talking about that, I look at it and I'm like, I hope the kids are covered under TIPRA or Medicaid or under one of the state-sponsored programs, because again, something like that, that's what the idea behind healthcare reform was to avoid our premiums and the exchanges and the insurance contracts between hospitals and providers, raising costs because everyone would be under the same umbrella, and then you wouldn't have a situation where you're covering the $18,000 broken leg is now somehow being filtered into the cost because it's going to be written off, and those write-offs aren't being brought into play. It's going to be hard to tell. And
it sounds like those same guys are the same guy. They're 20-something single, and they say, like you said, they got the big S on their chest.
Well,
I never get sick. I'm never going to break a leg. I'm invincible.
The other side of it too is not just those people that have got the S on their chest. It's the people that can't find a full-time job. I mean, when the age 26 came out, I sat there and was like, "Ugh, are you kidding?" My father booted me to the curb when I was 22 when I graduated from college and said, "I am not covering you. You are on your own, bye-bye." And I sat there and I'm like, "Well, that's not fair." And but I sat there and I was talking to people and kids. I live in Polk County, so I was talking to kids in my community who were 21, 22, 23, and they looked at me and they're like, well, if we work over 30 hours a week, we get docked because they would become benefit eligible. And I was like, that's not right, okay. But, you know, that's kind of the philosophy is that there's a lot more part-time employment already to avoid the provision of benefits. So, you know, I saw the reason and the necessity for having that type of provision in healthcare reform. It took me a while. But, you know, and again, those are the other issues too. It's you know, those people are also going to be caught in this loophole.
But that's a classic example of the wrong incentive. That
Right.
Now you're incentivizing them not to go out and get a job till they're 26 instead of at 21 because
Yeah.
they might as well stay on dad's plan.
My dad still wouldn't have let me do that.
No, well,
From our perspective, which is a little bit different, we at our plant have all full-time employees, so the part-timer wouldn't necessarily apply. But one of the challenges we have is we have been transitioning from a corporate level to a one program, Lockheed Martin HealthWorks. So at one time we had HMOs and other opportunities available to our employees. We are now narrowing that down to the LM HealthWorks plan. And we've heard from some of our employees, they really preferred the HMO opportunity, the in-network, out-of-network. And we have a 85-15% in-network, 65-35 for out-of-network. But part of the incentives that we're offering to promote a healthier lifestyle for our employees is a medical clinic. And we opened one at our facility here last August. It's great in the sense that we provide on-site assessments, testing, cholesterol screenings, other screenings, on-site flu vaccines and different things, which will preclude the copay thing. You know, we're trying to encourage our employees, if you can have it done here and meet with a nurse practitioner, reduce the amount of time that you would go wait otherwise in your doctor's office down the street, we can help you and provide that for you here. Now they're asking, well, can my family come? So, you know, not at this time, but, you know, at some point in time, we're probably going to have to consider that as well. But certainly the cost of the insurance is rising as well. We can't, you know, keep that down. But the choices are becoming more narrow for our employees. So to retain and to attract the employees, we have to be really cognizant of all of these things. But, you know, so we are taking a wellness perspective, and the incentives, even with our plan, are to complete your personal health assessment, to, you know, participate in preventive care, to work in, they talk at the walking plan, or Virgin Health Miles. Everyone wears the pedometer. You know, how many miles, how many steps can you take a day to get credits to your health plan so that it will defer your out-of-pocket expenses. So, you know, how much is that growing? We're gonna have to wait and see. I do see a lot more employees taking laps around the building and out walking with their pedometers and doing those sort of things. So trying to encourage wellness on a regular basis.
We see that being the model going forward. We feel like you have to have a partner in the health insurance of your employees. You setting up that clinic probably costs nothing for that employee to go to the clinic. If they get a medication out of that clinic, costs nothing to that employee as well, I would assume.
Well, they have the ability to prescribe medications. We're not dispensing medications right now necessarily, but yes, to go to the clinic, you know, reduces your time off work. You go down the hall, make an appointment to see the nurse practitioner. There's no copay, no fees. They can then assess the condition and prescribe medication.
We think those are the directions that larger employers will take. You can actually set them up where the whole family can come, which is very nice because now we're not worried about that $50 copayment to go see a physician or the $30 for a medication. The other things that we think will happen in the marketplace that will help, because we've been kind of negative today, shall we say? Market forces will dictate what comes down. And so we think what has happened in the past and what we've been used to in the past is a very fee-based, fee-for-service. I go in and get a hip surgery, I'm going to pay a fee for that surgery. What has happened though is I go in for that hip surgery and I get staph infection. Well, who gets rewarded for that staph infection? It's the hospital. They're the ones that caused the problem, but yet we reward them for causing that problem. We see things happening in the market that will dictate that the hospital act right, as well as the individual. And you'll see healthy living standards go up, at least that's the intent of the law. You will also see hospitals come more in line with reality of, oh, I have to really be careful here. I have to really watch before I get a staph infection problem or whatever, so that, because they're going to be penalized in those cases. So the market will adjust, and we will see things in the marketplace that will help our employees and ourselves become healthier, and also affect outcomes. And that's really what we're looking for, is not what's the penalty, what's the this, what's the that. No, we really are looking at having an effect on outcomes. So.
And that's a great point. And the idea is that what we haven't talked about today, and I did a presentation about a week ago to medical providers, is the additional onus on the quality of care. And you know, when you talk about the reasons for healthcare reform, you know, one of the big issues is that although we pay more for healthcare in this country than any other country, the quality of the care that is actually provided is lower than a vast majority of the, you know, of the nations out there. So, you know, that has been a concern, and there will be penalties if you have an increase in infections that occur as a hospital stay. Hospitals are going to now be held accountable for the procedures and the services they provide. And, you know, whereas before all that could be done was, you know, lawsuits were filed, and, you know, the only people that got any money out of that were the lawyers. And I'm a huge advocate of tort reform, even as an attorney, so, but don't tell any one of my partners. But the concept of that is that, you know, there is going to be other alternatives, and regardless how you feel about the federal step in, these penalties are not just on the employers. There is also an increase and a hope that, you know, wellness programs be established. There are you know, you can increase the benefits that you provide as part of wellness starting in 2014. You know, right now you're limited to 20%, but you can go up, I believe, to 30%.
With an exception, even 50.
And in some exceptions, 50. So you have this huge ability to create a healthier workforce and reward those people to do so. And in addition to that, the providers are being held, hopefully, what will be a higher standard of care. And it kind of builds on each other, because the higher standard of care means you can't fall below the lowest 25% on, say, staph infections. If you do, you're going to be, so, you know, the benefit would be, okay, if you've got the lower 25% here, maybe in 2 years, the lower 25%, even though they're still going to be penalized, will be a much higher quality rating.
While the model may change for larger employers, do you think that the small employer may benefit by the change in the marketplace as opposed to doing that individually?
It's a great question. The market, we think, will do something like this, and we are seeing it in Tampa, actually with a few big healthcare providers. Well, when I say providers, actual hospitals. They're looking at setting up small entities such as these free clinics, and instead of it being just down the hall, it's in a central location inside a community, and all the employers can access that community-based health plan or that benefit. Again, it's very preliminary, and the market hasn't really adjusted to what is coming down, but we see that that could be an opportunity for smaller employers to have the same type of outcomes or same type of benefits. We also know that there are matrix, there are tests, there are all number of different things that insurance companies have and that we have access to. It's just kind of hard to get to, that measure outcomes based upon what a physician does. Who is the best open heart surgeon? Who is the best knee surgeon? And you can find those out, you can find that information out and actually have an impact on the outcomes of what you're doing. Now, obviously, we just mentioned there's always that 25%, the lowest. Everybody makes mistakes, so sometimes that best physician might make a mistake on you. It can happen, but if you use those statistics, you know, if that individual has done that procedure over and over and over again and has done it really well, typically when he does you and that procedure, he's going to do it really well, as opposed to this is my first time doing it. So there's some things that we think will come down in the market that will help not only the large Lockheeds of the world, but also the smaller mom and pops.
If I can tag on to that, if the step back overall idea of the exchanges is the free access of information and easy to access via the internet, those pieces that go with it, whether it be for the small employer or the large employer, by market demands are gonna follow suit. So, as Patrick's mentioning, being able to see what's the best rated results for hospitals, being able to see what are the best rated results as far as wellness programs, that in best theory and best practice should be better and more readily available for not only the large employers but for their employees, so that you can make true consumer decisions. And you can say, if I go to hospital X, my out-of-pocket costs me $975, but that same procedure here is going to be $300. So, and because ultimately, whether it's driven by the marketplace on the provider or through the exchanges, when it comes down to a big chunk and mandated by the MLR, 85% of the cost of your insurance has to be claims. And claims are driven by providers and your employees. I mean, the people that use it. So if you can affect either one of those groups on either making smarter decisions or more prudent decisions that have better results, you're going to ultimately help lower that cost down. And so I think that as Patrick was saying, that information has to be readily available, and we're going to see it being driven and community share it.
That's really a great point. And as part of our Elm HealthWorks and the Aetna, which is the administrator of our program, on the website, they actually have ratings on the physicians and the hospitals, and you can do a comparison depending upon the type of procedure you might be looking for. So it's really comprehensive. I happened to be looking up something there about a week ago, and I don't even think I printed all the pages they were giving me on the steps, what to consider, how to go get your second opinion, and what to look for in the hospital. And so that is really great, and it's only helpful to anyone, employees at any level. So
and if we make wise decisions based upon our care, whether it be individual health, I lowered my cholesterol, whatever the case may be, or picking the right physician or the right hospital, that has an impact on the rates as we move forward. So there is reason here, and we may not agree with how we got to this point, but there is good reason as to why and what the intent is, what we're doing here.
Is there anything in there relating to this that, as a small employer, one of my employees brought in the spouse's plan, and she worked for a very large employer, and it showed all of their costs. They said, we pay 80%, here's the amounts and all that. And I went right to my agent and said, hey, we got to look at this plan. This is much better than what we got. Quote it for it. And she said, oh no, this is a lot more expensive than your plan. I said, no, it's not. She said, for you it is. So as a small employer, we found we were paying, or they were paying almost 30% less for the same plan that we would pay. Do those exchanges or anything like that help?
Well,
I mean, the biggest thing would be get a bunch of small employers, and then you got a bunch of people.
Well, and I think that might help with the new small employer rating rules on how they can underwrite plans on a forward-going basis. If you can because so much of when they underwrite a plan will depend on what information is provided, what the hell, your increases a lot of times will be based on how healthy your organization was. So if you've had any issues in the past, that can be reflected on yours, which might be more eaten up in a large employer as opposed to a small employer. And so those health ratings and those health underwriting perspectives may adjust that for small employers, because they're now putting them on an even playing field with respect to the only 5 things that can be looked at, which are really the only one that's that can be a give or take, basically, I believe, is smoking. So it's like, how many smokers do you have as opposed to non-smokers? But again, it's a capped level on how they can underwrite that. So that may help to bring those small employers.
Okay, but you're saying the capped level and all that, but still they're getting a huge volume discount regardless of the demographic.
And part of that playing field is going to shift, because currently, if you have less than 15 employees in the state of Florida, those rates are set with the state, and then they can plus or minus 15% on that based on the medical. Part of that is because that insurance carrier has to offer you a plan. You got people with bubonic plague, we have to offer it. If you have more than 50, they can choose not to insure the group. So they had a way to get out. So they were underwriting, and they were factoring in the fact that Lockheed Martin comes and we look at all their claims history, they're credible, we look at this and we can weigh out how the law of numbers works. Your 20-person group now, if they say we will take you at healthcare provider A, they will take you. There's not, I mean, they have to. So there's only so much how they can adjust it. And because of that, yet for their protection, you miss on the high end a lot of times. You're not going to be able to get the same plan for the same rate.
How do you think the whole thing may affect the industry and relationships we have with employers, insurance, and medical providers?
That's a tough question because we're looking into the future as to things that we just don't know. I was talking to a case in California that we were working with, a larger case, and they are looking at these exchanges this year. Well, only one insurance carrier has signed up to get into the exchange in California, and it's Kaiser. And this employer, it's a real problem because the employer has employees throughout the country, and Kaiser is in California and a few other states. So to really know where we're going to go with this, it's difficult to say. I do think, again, that the market will determine and will really dictate what happens in the future. It just depends on what the law actually shakes out to be ultimately. And that will have really ramifications on all of us. Healthy lifestyles, the way we access care, whether we purchase insurance through our employer or through an exchange or through a private individual, through a private agent. It's all going to change, and it's really difficult for me to see how that will be coming forth in years to come.
I think one thing to factor in there, and you're exactly right, there's so many moving parts, it's going to be different. But if you step back and say that part of the way that the law was written was that some of the inefficiencies that are currently out there have to be fixed to fund it, if that is a side effect of it, it may wind up helping the market move to where it should be, because a big chunk of what's supposed to fund healthcare reform is fixing some of the Medicaid fraud, some of the the double billing and problems out there. Now, whether or not the billions that are supposedly being wasted are going to get better when you dump 26 million more people into the situation, that can be debated. But the idea is that for this to work, some of these efficiencies have to happen, and the conversations that were held on a local level between providers and carriers and facilities are now going to be even more magnified because now it's a bigger system.
Exactly, and one other thing that has become, and it has become a trend, at least because of the changes in the marketplace, and we've seen it over the last couple of years, is that because of the changes to Medicare and the changes to Medicare reimbursements and the billing requirements and everything like that, a lot of the doctor groups and things like that are being acquired by the hospitals. So there's a new trend to have the doctors actually, whereas, I think like 20 years ago, the trend was all the doctors were going to have their own groups, their own for-profit entities outside of the hospital. That trend is now reversing because of the way the Medicare reimbursements are going to work. A lot of the doctors groups are now being acquired by the hospitals, and you're seeing some hospitals also be acquired. There's a lot of movement in the market, and I think part of that is that hospitals that don't have the necessary efficiencies or quality control are kind of getting themselves on the block to some degree, and in order to improve that, I think you're going to see some additional acquisitions happen.
If I could tie back into the first part of your question where you mentioned about how academia, you have the shift going to adjunct professors, and therefore they're not going to have. There's a term that's growing, which is your HR capital management is going to change going forward. So maybe you don't do a drastic change today, but as you hire in 2013, 2014, positions that would have possibly been full-time in the past may now be more 29 hours, 25 hours, so they don't even get pulled into
Don't run it that close.
I was going to say 25 hours if you don't even want to be pulled into the factoring there. But it's going to become a real big part of how businesses do business. I have clients that are in the hospitality and restaurant business, and that was already part of the way they did business, looking at shifting and variable hours. It's going to become something that drives. If you have multiple shifts at your plant, and it's going to become something that your HR department is going to have to make sure that they're ERISA compliant, make sure that these practices are well held. but it's going to change the ballgame. And unfortunately, groups that you would think wouldn't necessarily be part of that, just out of the reality of the cost, things are going to change.
And one thing, just to jump on that real quick, because we didn't mention it, and this is a big issue for 2013 going into 2014, is whether or not you have 50 full-time equivalents is determined in 2013 for 2014. So you need to start looking at your demographics now. Whether or not you're going to have to even be part of the pay and play is determined this year. In addition, determining whether or not someone is a full-time employee or a part-time employee can be a full-time job. The regulations on making these determinations are a little crazy, but if you have a lot of people that are working variable hours, there are factors that you have to take into account to determine whether or not they're full-time. And the basic gist, and this is very general, but I think it's important to point out, is what you can do is if you have people who are part-time or working variable hours and that's not consistently 30 or more hours a week, you can take a period of time, and it's called the look-back period, of anywhere from 3 months to 1 year. And then you look over their hours at an average and determine whether or not they worked more than 30 hours per week on average. If they did, then for the next stability period, whether it be 6 months, 3 months, or a year, those people are considered eligible and full-time employees for all purposes for the next, whatever stability period you create. But what's important about that is you need to start figuring out how you're going to calculate that. I laughed when people said, oh, we're going to go to all part-time employees. I'm like, it's so much easier to figure out full-time employees. Go with full-time employees. But those part-time employees, those kinds of things will need to be considered and designed and put in place. I'm just throwing that out.
And when she says that could be a full-time job, that is such an understatement, because not only are you doing this for your existing employees, but for new. And you'll enjoy doing this with your new employees as well. So you have actually two calendars going at the same time with look back as well as going forward. And once you've determined it, they're in that for the same period of time. So there is, you're right, there's a lot that goes into it, and it's going to affect, you mentioned employers that just want to get back to making, making what they make, making their widgets. The problem is even if you say, I'm out, I'm not going to offer, I'm going to the exchanges, those kind of things are still going to be factored in. I mean, there's still going to be paperwork, there's still going to be collection of data. It's a different ballgame for everyone.
And from a cost side, we've sort of created this monster. For 100 years, we've developed this culture where the insurance covers your medical costs. You don't shop. You don't care about where the cost is more efficient, or you can't even find out who's better, who's worse, all this information. You just go, you don't pay, you don't look at the bill, you don't ask what it's going to cost till you're all done, and then the hospital's $18,000, and of course the insurance company's got a deal for $7,000, and even in the hospital, oh, here, you want an aspirin? You don't say, well, how much is it going to cost? Oh, it's $50. No, I don't need it that bad.
Except that there's certain hospitals that will ask you to prepay for certain types of procedures and things like that.
But we've done this for many, many years, and we've sort of created this monster, and I don't see how any of the changes of more government control over the system puts us into a more consumer, market-driven kind of an approach. So I don't see where the cost equations change. I just see it getting more expensive at double digits every year again, and at some point, how do we pay for it? If it goes 10% a year, and it's going more than that, but even if it was only 10% a year, we keep projecting out and saying, how much longer can we do that? Because we can't raise our prices that much.
You got it.
So we're stuck.
Big thing. Well, look, I think we hit it right on the head. Stop at 9:30. I'd like to thank you all, and I think what I got out of the last part of the discussion is kind of like the universe. Maybe out of this chaos, the order will evolve as we do it, but it's going to need a God somewhere to do that. But I'd like to thank our panelists for everything that you provided to us today, as well as Andy Malcolm and Advanced Protection Technologies for allowing us to use their GoToMeeting account. So we've got that started. That's good. And Zach with Newhouse Media Group, who's filmed this, and we'll get this online so that everybody else can share it. And thank you all for your time for coming out today.
This presentation is made available for educational purposes only to provide you general information and a general understanding of the law. It is not intended to provide, nor does it constitute legal or tax advice. The presentation should not be used as a substitute for specific legal or tax advice from a licensed professional attorney or tax consultant that you have engaged for that purpose. Further, the subject matter contained in this presentation is complex and subject to change. Any tax statements in this program are not intended to suggest the avoidance of U.S. federal, state, or local tax penalties.